Good evening, everyone, and welcome to the second session of LEJEndo, Lister Endometriosis Journal Club, which happens on the 6th of every month at 6 p.m. UK time. LEJEndo is a virtual journal club, and the closest I can give an example of is like a morning breakfast show of what you see on television, people going through what's in the papers today. And like those shows, it's going to be very informal. And like those shows, we're not going to be able to go into too much detail for each paper. The idea simply is for us to share with you what we've read and found interesting. And I think interesting is a very important word here. That doesn't mean that we endorse what's in those papers. It doesn't mean that we even think these are high quality paper, all of them. Some of them are. And there is no time to properly critically appraise those papers. But we're hoping to build a community and to start talking about papers that have been published, because we're all busy. Most of us are clinicians, and there is no time to read whatever is published. But hopefully we're going to talk about some interesting papers. And each month, the team, the LEJEndo team that you can see on screen, go through what's been published, and we choose 6 papers out of those. Those are the papers that we think we want to talk about. And then we choose another 2 as featured articles, and we ask their authors to come and talk about those articles to us. And today we have 2 excellent speakers, people who I very much respect and think have done a lot for the world of endometriosis. Gabi Moad, my colleague and friend from Washington, who leads CEAP, CEAP, and is a very well-known, well-respected robotics surgeon and has done a lot of work in the field. And Andrew Horn from Edinburgh, who I think we should all be very proud of. He's done a lot for the world of endometriosis, particularly in the UK and internationally, and he's hosting the World Endometriosis Society conference in May, and we'll hear from them a little bit later on. The format of the meeting is going to be first 2 of the LEJEndo team. Tonight it's going to be Avril Bachi, who's my current clinical fellow, and Mikey Adamczyk, who's my consultant colleague in CMIC London and also at St. Peter's Hospital, are going to talk about 3 of the selected papers. Very briefly, it will be 2-3 minutes per paper. We will have a couple of polls that we will launch, and we'll ask you to tell us what you think about those questions. Then Gabi will talk about his work on diaphragmatic endometriosis. Then we'll have a little bit of question and answer and discussion, which you can use the Q&A button to contribute. And then we'll go to the 3 other papers that Mikey and Avril will present. And then Andrew will present his work, which is a review published in an excellent journal on endometriosis. And I think this is an example of how this journal club is not about a particular methodology. We have reviews if we think those reviews have been done with a quality that would merit talking about, like Andrew's work. It can be surgical presentations, or it could be basic science work that we tend not to read, at least I tend not to read. And a last couple of points. to thank Carl Storz UK and John Flanagan in particular for their help and support for these series, and to say that we have no conflict of interest. We have not accepted any financial backing or sponsorship. And also to mention that we're aware now that there are some patients in the audience. Everybody is welcome to join, but I have to apologize because the meeting is not designed for patients. So if we use a lot of jargons and we're being boring, please excuse us. But you're always welcome to join and see what we talk about and what we discuss. So I'm going to ask Avril to share her screen, and let's start.
Okay, so good evening, everyone. I'm actually going to start tonight with the systematic review and meta-analysis. So this is a publication from PLOS ONE. It's slightly older. It's from 2017, from October 2017. And it looked at, it's actually a publication from a Chinese group, and it looked at the effects of acupuncture in the treatment of endometriosis-related pain. So I just thought it could be quite a good starting point for today. Avril, can you go to the next slide, please? Okay, so what they did, they searched 6 databases for randomized controlled trials. They picked up 10 studies involving 589 patients, and they were looking at 3 main outcomes: variation in pain levels, variations in the peripheral blood CA1 to 5 levels, and clinical effective rates. They've included patients or women with reproductive age that had laparoscopically confirmed diagnosis of endometriosis, and the exclusion included patients with primary dysmenorrhea, where there was a known absence, or where there was an absence of known pathological condition, and patients with asymptomatic endometriosis. The included studies comprised of a total of 295 patients, and a further 294 patients were in the controlled group. The age varied between 13 to 52, and the interventions were all patients that had acupuncture, while the controlled group had placebo effects, placebo, also known as sham acupuncture. Most of them, unsurprisingly, were done in China. There was out of the 10, and 1 of them was done in Boston. However, the sample sizes were quite small, ranging between 8 to 36 patients per arm. The 6 trials that they looked at compared pain, and mostly main pain levels, between acupuncture and the controlled group, and analysis of pooled data showed that the acupuncture has a positive effects on primary pain as in comparison to the controlled group. Further 4 trials compared peripheral blood C1 to 5 levels again, and yet again it showed that it had some positive effects on peripheral blood C1 to 5 as in comparison to the controlled group. And 7 trials compared the clinical effects rate of treatment between acupuncture and the controlled group, and again it showed positive effects. Next slide, Avril. So what I really wanted to know was, what was the mechanism of action of acupuncture? It's widely, I think we can say that it's already in the NICE guidelines. It's something that we can access, but I personally didn't really understand what was the mechanism of action. And they described it into 3 categories: acupuncture and analgesia, acupuncture and the endocrine function, and acupuncture and the immune function. In terms of analgesia, it seems to be working by alleviating pain, by increasing the pain thresholds, and that's through the release of neurohumoral factors. In terms of endocrine, it suppresses serum estradiol levels, and in terms of immune, the acupuncture stimulates increase of cytotoxicity of natural killer cells. So I've just found that quite interesting in terms of acupuncture, and that would be probably a good place now to maybe put the poll up to see how many of you use acupuncture in your day-to-day practice.
And it was interesting, Mikey, that they used host and panelists can vote. They used CA125 in some of those studies to monitor endometriosis. Of course, we know that that's not a marker for endometriosis severity, but I guess that just shows that there was some variability in the quality of studies as well.
Exactly. I think it's very good. It's a very good point, especially if we have any patients listening to it. So that was a very good point that you've made, Shaheen, certainly.
Okay. So
Okay.
while people are voting, let's go to the next one. So Mike, another point I wanted to make, I think acupuncture found its way in one of the national guidelines. If I'm not mistaken, Andrew may know this better than I do. I believe that was included in the NICE guidelines, or is that ESHRE guidelines?
No, you're right, Shaheen. It was included, but it was more a statement to say that sort of there isn't enough evidence to recommend it, but there isn't evidence to say we shouldn't do it, if you see what I mean.
Okay. Thanks. All right.
All right, so the next paper that I will be discussing about is a prospective cohort study by a group from Paris, and this study was published in Fertility and Sterility in 2021. And essentially, this study was looking at women with infertility and bowel endometriosis and whether or not first-line ART should be suitable for them. And essentially what they found was that there's a satisfactory live birth rate in bowel endometriosis patients undergoing first-line ART. And this study is slightly different from other studies because in other studies looking at live birth rates as well, they did have a proportion of women who had previous surgery for endometriosis. However, in this study, they excluded anyone who have had any prior history of surgery for endometriosis. They included women who had endometriosis-related infertility, who was less than 43 years old and had bowel endometriosis. And they defined bowel endometriosis by at least muscularis invasion of the bowel on MRI scan. And the MRIs were reported by only one senior radiologist in the center. They also excluded women who had oocyte donation and was also involved in another ART research protocol. And the main outcome for this study was the cumulative live birth rate. And that means the proportion of women who have had at least one live birth, whether or not from one transfer or subsequent transfer. They also looked at endometriosis-related complications such as worsening pain symptoms, uterine rupture, bowel obstruction, and this is because ovarian stimulation is thought to cause the progression of endometriotic lesions as well. And in this slide, this table is quite busy, but I will take you through it. So up here, they had 101 infertile women with bowel endometriosis and no previous surgery. About almost 80% of these women had primary infertility, and 73% of them had endometrioma. Half had unilateral and half had bilateral endometriomas. The average size was about 3.6 centimeter. They had at least one bowel lesion, and 88% of them had associated adenomyosis. So out of this 101 infertile women, they all of them then undergone in total 176 cycles. Only one woman underwent 4 cycles. Most of them underwent 1 cycle. And about 201 embryo transfers were performed. And so about 73% became pregnant, 64.4% had a live birth. And what was interesting is they assumed that the women who did not return to the clinic did not have a live birth. So the cumulative live birth rate after 4 ART cycles was 64.4%. There was no endometriosis-related complications. About 7.7% had preterm birth, 10.8% had low birth weight, and 40% had a cesarean section. But I'm not going to go into the obstetric outcomes and perinatal outcomes because my colleague Kyle has discussed this in our last LEJEndo session. They also did a univariate analysis, and this showed that the duration of infertility of greater than 30 months was associated with a statistically significant low birth rate and low ovarian reserve. and only AMH of less than 2 remained an independent negative predictive factor for live birth rates. So in this study, they concluded that the cumulative live birth rate was satisfactory for women undergoing ARTS first line and those with bowel endometriosis.
That's interesting. So, April, you may want to show us the result of the previous poll and launch the second poll for this one. For as long as I remember, the discussion between should we do IVF first or should we do surgery first in patients with bowel endometriosis has been going on. I can't remember a time that it wasn't part of a debate. And interestingly, next month we are going to have a featured article. Ben, correct me if I'm wrong, from a team that have shown a meta-analysis of all RCTs done to answer this question. So we need to remember that this study, whilst really encouraging, and it is a low-level evidence, but I think it's really good, the fertility that they get without surgery in these patients undergoing IVF, 60-something% is really phenomenal.
You're absolutely right.
When is the featured article, Ben? Is it in March or April?
In March, we're going to have Professor Camona talking about the impact of surgery for deep endometriosis before IVF.
Okay, so that's interesting.
Be very interesting.
Yeah, they did a systematic review, and
yes.
They showed that surgery does improve the fertility. But as I was telling a patient just half an hour ago, the question has not been answered properly yet. So just we need to consider each patient separately and discuss the options with them. And it needs to be a decision in a multidisciplinary fashion with the fertility team as well. So, Avril, do you want to launch the poll? What I want to ask everyone is sort of unrelated to this. So first of all, the answer to poll 1, 90% don't use acupuncture. And I have to say, I don't routinely use acupuncture, but actually it's something that maybe we should consider at least talking to patients about where pain has not been responding to usual treatments. So what I'm interested in knowing is, I'm not talking about the evidence. I'm talking about personal experience of those who are endometriosis surgeons and have experience in this field. Do you think that IVF, patients who've had IVF tend to have worse disease when you operate on them? Is that what you have seen in your practice or not? Okay, let's talk about adenomyomectomy.
That's right. Let's talk about adenomyomectomy. So I've got a interesting paper. It's slightly older. It's from March 2018. It's from Fertility and Sterility. It's a very well-known paper by Osada, uterine adenomyosis and adenomyoma surgical approach. This is they looked at 2,356 cases reported worldwide, and about 90% of them were done in Japan. And they've noticed that there was a pregnancy rate roughly between pregnancy rate between 17 to 72%, with 449 pregnancies, and about 80% of them resulted in live deliveries. However, they reported 24 uterine rupture, which is pretty high at 6%. Next slide, Avril.
Yep.
They concluded that there was definitive association between uterine ruptures and the use of powered instruments. However, there was no reported uterine ruptures resulting from using a cold knife, a surgical scalpel. What they also noticed was that focal adenomyosis lesions can be treated laparoscopically. However, diffuse adenomyosis must be treated by laparotomy, or preferably by combination of both. So that sort of goes along the lines what we all believe. Next slide. the risk of uterine rupture is believed to be increased subsequently in subsequent pregnancies following laparoscopic procedures. And they've also concluded that open surgery is safer than laparoscopy and this is really because of complete excision of the lesion. So they're talking about excising the adenomyoma completely to avoid closing the uterus with adenomyosis to adenomyosis. So that's my presentation of that.
Thank you very much. So do we have the result of the poll? Okay.
Sure. No?
So no. And I think the evidence isn't there to prove that IVF makes endometriosis worse, but it's something that I don't know, some of us have seen and feel and believe, but again, if we are talking evidence-based, I don't know if we have the answer. Maybe we'll go back to it and I'll ask the panel to talk about this as well. But for now, let's give the host
I have.
To Gabby, and I did introduce Gabby. Gabby really doesn't need introduction. He is a very good friend and an excellent surgeon. He has done a lot of work on robotic surgery as well as laparoscopic surgery. And I am absolutely delighted and I'm very grateful to him for accepting my invitation. Gabby, the floor is yours.
Thank you so much today. This is actually very, very interesting for me. And then it's always very good to share the science together with friends and colleagues. So today I will be speaking about our recent paper published in Fertility Sterility about the robotic approaches to diaphragmatic endometriosis. My presentation is short. We're going to talk a little bit about the background. How did we start this paper, the approach and positioning specific to robotic, the docking and port placement, and the different surgical technique for diaphragmatic endometriosis. So a recent study published in JMIC with the group of Mauricio Abrao and Roseanne Coe about extrapelvic endometriosis, a systematic review. Bowel, most of the time, is not included as an extrapelvic endometriosis because we know, as a matter of fact, if we look at the anatomical demarcation, appendix is the most common extrapelvic that is outside the pelvis. But when you exclude bowel, diaphragm will become the most common location of extrapelvic diaphragmatic endometriosis, accounting for 1% of all cases of endometriosis. So it's very important to look for the diaphragmatic endometriosis, to ask the questions before, because if we have a 0-degree scope trying to chase diaphragmatic endometriosis during surgery with a patient in lithotomy position or a flat position, most likely we're not going to find anything. You have to look and search deeper for it, depending on the symptoms of the patient. And as you can see here, this is all the locations basically where extrapelvic endometriosis could be present. So when we look at the thoracic endometriosis, it's divided into 3 portions: diaphragmatic, pleural, and lung endometriosis. And then 80% of those are diaphragmatic endometriosis. 70% of the diaphragmatic endometriosis are associated with pneumothorax, whether catamenial or non-catamenial. Most of the diaphragm is on the right side, around 80%, only 20% are found on the left side. So understanding all these kind of statistics, sometimes it is very important to put the clinical diagnosis or raise the clinical suspicion so you can order the appropriate imaging. Chest X-ray sometimes could yield some form of endometriosis, CT scan as well. What we do in our practice is MRI. We look at the diaphragm on a fat suppression, T1, and then you can see mild lesions, sometimes foci of diaphragmatic, sometimes bigger plaques in more severe cases. The most important thing is to ask what are the slices that your MRI do, because most of the MRI for the pelvis are between 5 to 8 millimeter slides, which will not lead or yield anything. It will be negative most of the time. So you have to request a thinner slices when you do the segmentation with an MRI if you want to yield higher results. Again, extensive diaphragmatic lesions could appear as plaques around, and that's again on fat suppression sequences. So when we look at diaphragmatic endometriosis in 50% is associated, 53% is associated with pelvic endometriosis. So now here, the dilemma comes, whether are we doing these things at the same time or are we doing things separately? Because this is what is very important, that we don't talk about it, whether the risk of mediastinitis is increased, the morbidity from mediastinitis is increased. So are we doing with endometriosis a clean surgery or a clean contaminated surgery or even a soiled surgery, dirty surgery? So these are the questions that every clinician or every surgeon should answer before we do that stuff. So for positioning, we can have two types of positioning: the lithotomy position, which is what we use for GYN, because it allows us to have adequate access to pelvic surgery, and at the same time we can access the diaphragm. We can have appropriate exposure of the diaphragm. With the new XI robot and with the table motion, you don't need to redock many of the times. The disadvantage of this is many times you have to mobilize the liver, you have to take the falciform ligament or sometimes the coronary ligaments of the liver to enable a better access, because most of the diaphragmatic endometriosis happen on the tendinous portion of the diaphragm, and then most of them are in the posterior half of the diaphragm rather than the anterior half of the diaphragm. So there need to be some digging around the liver. And the lithotomy position many times limits the access to the left side of the diaphragm. Now, when we look at the lateral decubitus position, when the patient is lying on her left, her arm are above her head, this will allow us easily a better access to the diaphragm, and then many times the weight of the liver will fall down and you don't need to mobilize the liver. On the contrary, if you're going to do concomitant pelvic endometriosis, you have to redock, you have to reposition the patients. That would take a long time. So the lithotomy position, when we do lithotomy position, there are two options with the robot. Either you dock the robot towards, as you're doing a foregut surgery, where you rotate the boom, or you dock the robot in the regular position that we do. And then at the same time, with that regular position, we are able to access the pelvis and then part of the diaphragm. We like in diaphragmatic endometriosis to place the port a little bit higher on a lithotomy position, even though the instrument of the newer generation of Da Vinci platform are long, they can access the diaphragm as well as the pelvis, but it facilitates the access to the diaphragm without being hindered by the liver. So we place them usually either at the level of the umbilicus or even above the umbilicus. When we do the table motion, as you can see in this video, this is using the same docking, just manipulating the arms so we can access the diaphragm up and at the same time rotate the patient, move the table without rotating the patients to access the pelvis. So this is a common technique that we use for multidisciplinary cases, especially when we have a robotic surgeon doing something on the gallbladder at the same time, or a different quadrant of the surgery at the same time doing pelvic surgery. So with the lateral decubitus, we want to ensure that we have an access to the diaphragm really well. So we place the ports, the optic port at the mid-clavicular line, two other ports, one on the anterior axillary, one in the midline, and we place the assistant port around the umbilicus. And this will give us the triangulation, even with the robot, to access the diaphragm and be able to perform surgery and suture ergonomically. Now, this is the positioning of the lateral decubitus positioning of the port. Now, for the techniques of diaphragm, we can do three things as if we're doing the bowel. You can do peritoneal stripping on the diaphragm, you can do diaphragmatic shaving, and by the way, peritoneal stripping only on the muscular part of the diaphragm, because that peritoneum fuses with the tendinous part of the diaphragm. It will become impossible to separate them. The shaving is when we don't have a full thickness. Usually, if the patient is lucky enough having part of her diaphragmatic endometriosis on the muscle with the tendinous portion. And then the second one is full thickness diaphragmatic excision. And then one other thing that we realized that even though VATS has been used tremendously, but now with the robotic platform, we got the thoracic surgeon to do a transabdominal lobectomy or through the abdomen, through the diaphragmatic hole. So that is also something to discuss with your multidisciplinary team. So the peritoneal stripping, it's very easy, as I mentioned, on the muscular aspect, because the peritoneum is completely separated from the muscle. And then you can see the CO2 gas will enable you to get through that peritoneum. And then doing such excision is very easy and very simple. It becomes like an easier than peritoneal stripping. And then maintaining a good visualization and better ergonomics will enable you to do these portion of the surgery very easily. The shaving of the diaphragm is whenever, as I mentioned, we have lesions in between the muscle and in between the tendinous part. And you can see here, being able to rotate the camera is a great feature. What we recommend when we do the shaving is we want to work at a lower energy, around 10 to 20 watts, to minimize the fasciculation or the contraction of the diaphragmatic muscle. That is better. We can ask anesthesia to stop the breathing of the patients if we're doing something closer to the heart. Sometimes we like to reinforce that, and some other time we don't reinforce it. So we use a VLOC 3.0 many times to suture the or reinforce the diaphragm in that sense. So this is the shaving. Shaving is less and less, and especially when we found smaller lesions, and then mostly on the joint between the muscular and tendinous part. The full thickness diaphragmatic excision requires many times mobilization of the liver, whether through the falciform, which is easier to mobilize, or through the coronary ligament of the liver, which are hidden behind the liver. This segment contains some blood vessels, some arteries to the falciform ligament, but the remainder is very easy. And then, as you can see, being able to mobilize the liver prior to performing the procedure will enable you to have a better access to the endometriosis lesions, rather than trying to start and open the chest, and then after that, try to remobilize the liver. That will become more difficult. Again, we apply the same rules. We try to do the minimal possible to excise optimally the endometriosis. Whenever the thorax is opened, usually we don't perform any double lumen intubation. We notify anesthesia, and then what we do is we excise all the complete lesions. We do a chest inspection whenever we do the surgery, and you can see most of these lesions are transpleural. Whenever you have deeply infiltrative endometriosis, you can see more and more the chocolate coming in. We inspect the cavity to see if there are any additional pleural with the 30-degree up and 30-degree down. And then the lung also could be inspected. And then the thoracic surgeon, if they want to do sometimes a partial lobectomy, they can throw in a stapler through the abdomen. We realized a few tips for diaphragmatic endometriosis. We don't like to use an air seal, for example, because it forces the air to be pushed, even if it's a CO2, but still it can collapse the lung. And then we prefer to do the diaphragm at the end of the procedure, in a sense that we're going to desufflate the pneumoperitoneum after, and we can ensure that there's not much residual CO2 in the lung, even though if it is resorbed. The suction goes in, the anesthesia is requested to do a Valsalva while we're applying continuous suction. Then we cinch the last stitch while the assistant is removing that, and then we close. Many times with V-locks, we don't put knots, but I like to secure the V-lock with knots, because the diaphragm is an active muscle and it's going to be used straight after surgery. So to minimize the opening of that, even though there's nothing that would happen if those two cavities are communicated, the only risk is risk of herniation, whether of the liver or the bowel. So conclusion, it's very important to know what are you going to do. Choose a lateral or a lithotomy position, depending on the severity of the diaphragmatic endometriosis. The robot will enable you to do more complex cases with better ergonomy through a an easier instrument handling in those tighter space. And then we all agree that this is an added value to optimally remove all the diaphragmatic endometriosis. Thank you so much, guys.
Thank you very much. That's great. So a couple of questions. One is from Andrea. Andrea Billet is my consultant colleague, thoracic surgeon. He's asking, is there a risk for denervation injury to the phrenic nerve when we do a total abdominal approach? So would that be a reason to prefer a thoracic approach or a both side approach?
So whenever we do any surgery on the tendinous part, we're gonna injure portions of the phrenic nerves, because the phrenic nerve starts, opening in that. But the main branch of the nerve is particularly very posterior, and then it's closer almost to the vena cava, and then we don't get to this area rarely. Now, definitely there is a theoretical risk. Doing two approaches is important, but most of the time when we have a fuller, thickness lesions, there's no other way. So if we know we're going to open to excise that lesion, we have to accept that we're injuring sometimes the nerve. But if we do a partial excision from the abdomen and a partial excision and leave the most of the endometriosis within the muscle or the tendinous portion of the diaphragm, I think the patient's symptoms highly will persist. So it comes as a discussion with your thoracic surgeon, with the patient themselves, and this is how we made those options. Many times the thoracic would prefer to do VATS to assess the situation, especially in cases of catamenial pneumothorax, or many of the patients have already seen a thoracic before they ended up with us. For us, if we diagnose those in the office, we have high suspicion, we have confirmation. Usually we let the thoracic surgeon be present, or at least consult with the patient, but most of the time we can do those surgery with no thoracic surgeons if there is no lung involvement, unless there is a possibility to put a mesh on the diaphragm. But through my years of experience doing diaphragmatic endometriosis, I have only one case where we had to place a mesh, and this is when you almost excise most of the diaphragm. Other than that, the diaphragm is pretty elastic.
Okay, so Kai, do you want to go through the questions that have been posted? There are 2-3 more questions.
Grand. So from Ahmed Sanad, essentially, what would be the best approach to diaphragmatic endometriosis laparoscopically, and what would be the best instrument to mobilize / retract, apply pressure to the liver?
When we did it laparoscopically, we used the ultrasonic energy to mobilize the falciform and the coronary ligament of the liver. And then in laparoscopy, you can place the patient in lateral decubitus position, because it gives you better ergonomic than even to mobilize the liver, sometimes you have to subluxate the liver, which is like take most of the ligament of the liver and being able to pull it. With the lateral decubitus approach in laparoscopy, it gives better ergonomic to the surgeon and at the same time minimize the mobilization of the liver. So that's what we did before laparoscopically. Ultrasonic energy is good. And liver, many times we see a lot of foci on the liver capsule. Liver, it's easy to be treated. Most of the, if you watch liver surgery, they use monopolar and then they use even harmonic. So many times when we start gaining experience about different organs that we're not familiar, I would encourage a lot of surgeons to watch different specialty, how they handle, and at least have some sort of an informal proctoring from a colleague that does foregut surgery or liver surgery during the first case to gain trust and gain confidence, especially, and then be able to handle some of the mishaps that could happen within the first couple of cases that you do those. So it's always encouraged to scrub with another surgeon at the beginning of the experience.
And then from Andrea Billet, in your experience, when you find peritoneal deposits on the diaphragm, is it worth to explore the pleural cavity with a VATS to check the pleural surface of the diaphragm?
Well, this is an amazing question because this is the same question we would ask when do you order a colonoscopy for bowel endometriosis? And usually colonoscopy does not help us at all, except if there are symptoms of bleeding or occlusion. And then the same thing, if we don't have a catamenial or any, hemoptysis, any signs of lung invasion or severe pleural invasion, I think it could be done for the patient, but most of the time, even it's very similar to the gastroenterologists who do not have an experience with endometriosis. They could do a colonoscopy, they could see lesions, and they are unable to identify them visually because they don't work commonly with endometriosis. And very similarly, to request a recommendation for everybody who is a chest surgeon to do that. Many of them do not do endometriosis, or it's been a long period of time. So they're not very familiar, with all due respect to their skills, with the different visualization of endometriosis. So that will be most common, most of the time negative. And that is another major surgery for patients. So I think we like to minimize the number of surgery, but if the thoracic field surgeon feel in our practice strongly about the VATS, we would definitely refer the patients. But I don't see that kind of systematic for everybody with peritoneal or diaphragmatic intra-abdominal to do a VATS unless they have severe symptoms of hemoptysis or catamenial pneumothorax or non-catamenial even.
And then I think final question before we move on, if there is a patient with full thickness diaphragmatic endometriosis without specific symptoms, would you still recommend to resect it or not?
So for us, like the endometriosis is not cancer. And then the most important thing that we do is to try to improve their quality of life. We've seen many patients that have a lot of lesions on the diaphragm, but they don't have any symptoms. Even if you ask them, they don't have anything. So we'll let them, we'll leave them alone. We can monitor, we can educate them, we can encourage them. At the end of the day, the diaphragmatic endometriosis is a surgery that carries a lot of risk. So if the patient is asymptomatic for a benign disease, I don't think there is a justification for any of the risks if the patient do not have any symptoms.
That's fantastic. Thank you very much. Now, I'm aware that we're running behind a little bit. So, Andrew, if you need to, if you are limited for time, we can do your presentation first and then do the rest of the papers. If not, can we continue with the?
Okay. Carry on. Yeah.
That's great. So before we move on, if we have time, let me just abuse the situation a little bit, because we've now asked Andrea to come up, and I wanted to ask him a question. Andrea is my good colleague who's a very skilled thoracic surgeon. Andrea, in what situations do you use mesh?
So I usually use mesh when, again, the defect is pretty big. So when you have to excise not only the central tendon, but part of the muscle in that case, and I see too much tension. Sometimes I use the mesh because if you tight too much the diaphragm, there's a risk of rupture. And also some patients, they experience quite severe pain because all the insertion is on the rib cage. So in that case, I use a mesh, and my preference now is to use a biological mesh over the Gore-Tex mesh because I noticed that Gore-Tex mesh can cause more chronic pain compared to the biological mesh. Again, they're like plenty, but that has been in my experience.
Okay. Well, that's great. We've got one coming up in the next couple of weeks, don't we, Andrea? We're almost removing all of the diaphragm. So
yes,
I think that's going to be. And then the other question is, we've seen in the last couple of months, me and you have seen a couple of cases with pericardial endometriosis, right under pericardium. And when I asked you what on earth are we going to do on that, you just said, well, we excise it. Is that not a big deal with you open the pericardium and close it again?
No, it's not a big deal. Of course, again, it depends on the defect of the pericardium. If it's a small defect, you can directly repair it. Sometimes you can even leave it open because having the two lungs in place, the herniation is really unlikely. The herniation may happen more frequently on the left-hand side for the position. So in that case, you may have to put just interrupted stitches. If the defect is significant, of at least more than 4 or 5 centimeters, then you should put a mesh. And in that case, we use a non-absorbable mesh like Gore-Tex because the biological mesh can cause a risk of pericarditis on the diaphragm. On the pericardium.
In our experience, also, even if we're going to repair it, then we leave a little bit open because to avoid the tamponade from the inflammatory fluid.
And I agree because most of them, they develop a minimal degree of pericarditis and a little pericardial effusion. So even when we suture, we leave it like loose or some space in between the stitches. Otherwise, they come back with a small pericardial effusion and more issues than benefit from the operation.
But the most scary part of my life is when you get the pericardial fluid, when you excise the pericardium. When the pericardial fluid jumps out into the abdomen, this is the scariest part. Like, why am I doing this?
Well, I'm going to leave the operating room when that happens. Not my problem. Okay, so let's go back to Avril and Mikey and see what else they've got for us. Avril, are you going first?
Yes, so we have 3 last papers to discuss. This one I'm going to be doing is a short and simple one. It's the first RCT comparing Dianagest and the combined pill on the treatment of endometriosis-associated pain. And this paper was produced by a group from Beirut Medical Center. And what they found was giving Dianagest 2 milligrams a day was as effective as giving the Yasmin pill taken in a continuous fashion for about 24 weeks for the relief of pain and the improvement of the quality of life. They started off with 115 people. They included those who had histologically proven endometriosis from stage 1 to stage 4, or radiologically confirmed endo. These patients need to have at least 6 months of pelvic pain like dysmenorrhea, dyspareunia, and has a baseline visual analog score scale of at least 4. And then these patients were then randomized to the Dianagest group or to the combined pill group. Of course, some were lost to follow-up, some discontinued because of side effects, because of falling pregnant. And at the end of the day, they had 25 in the Dianagest group and 26 in the combined pill group. And what they have found was that both of these treatments did reduce the endometriosis-associated pain, and the reduction was most pronounced in the first 12 weeks. For the Dianagest group, the score went down from 8.4 to 2.1, whereas in the combined pill group, the score went down from 7.9 to 3.38. both were statistically significant, but when they compared both of these two treatment arms, there was no statistical significant difference. This was the same with the quality of life as well. Both showed reduction in pain, improvement in emotional well-being, self-image, but when they compared both of these treatment arms, there was no statistical significant difference. In both of the treatment groups, the patient reported that the side effects were mild, they were tolerable, but the incidence of adverse side effects was more common in the combined pill group. So in conclusion, they concluded that DiENEGES was as effective as the combined pill in managing pain associated with endometriosis, but had lesser side effects than the combined pill.
There was, Avril, a study, I can't remember if we presented it or not, that compared DiENEGES with GnRH analogs.
Yes, there's actually a lot of studies comparing both of them, a lot of RCTs as well. Again, they showed that DiENEGES was not inferior to GnRH analogs, actually.
Okay, okay. Thank you. What's next?
Mikey, you're next, huh?
Am I next? Okay. So I've got this paper that I want to present today. This was recently published at the end of last year in the Journal of Clinical Medicine. I think before I start, it's important to just express that we're not endorsing this in any way. This is simply just a presentation of a publication that we recently read. This was published in 2021 by the end of the year, and it was actually published by a group from Warsaw, from the Medical University of Warsaw. Expression of FUT for mRNA is increasing endometrium from women with endometriosis. So if you can go to the next slide, Avril. So it was a relatively smaller study consistent with 77 patients. It was done between 2010 and 2015. The endometriosis group consisted of 49 patients where the disease was actually diagnosed on laparoscopy and histology. The severity of endometriosis was classified using the revised American Fertility Society criteria, and the controlled group consisted of 28 women without any clinical or sonographic symptoms or signs of endometriosis. And biopsies were taken during routine sort of cervical smears and removal of cervical polyps. The exclusion included cervical dysplasia, grade 2+, or dysplasia of the cervical polyps. Okay, all of the patients and subjects had normal menstrual cycles. None of them suffered from any other chronic endocrine or any other autoimmune disorders. And they had not been subjected to any hormonal treatment or any pharmacological treatment for at least 3 months prior to the study. And the tissue samples were collected in the mid-proliferative or mid-secretory phase, and the biopsies and endometrial samplings were done with pepper biopsies, or pepper cutters. The QRT-PCR analysis showed that the relative FUT4 mRNA expression was significantly higher in the endometrium sample from women with endometriosis when compared to the control group. So I thought that would be quite an interesting one to show it to everyone today.
Yes, I want to pretend that I understood it, but
So do I. So do
I don't know, guys. Have you, Andrew, Gabby, have you heard that we've got some tests now in actual practice? I heard it 2 days ago for diagnosis of endometriosis, because I'm sure you're going to cover some of that in your talk, Andrew, but I heard yesterday from a group of GPs that a lab is offering a saliva test. And interestingly, we did present that study last month from the team in Paris. Have you heard that? Is that actually in?
Sorry, Gabby, carry on.
Yeah, Gabby.
I was thinking if that's the Afshin Cécile Isser group.
No, it is Sofiane Ben Ifalla.
Ben Ifalla, yes.
Andrew, have you heard of that?
Yes, I have heard of it. I think they're sort of launching it or promoting it in the UK. It's been available to buy in Switzerland, I think. I think we have to be a bit cautious, and I think you presented one of the papers, but it's only so far been studied in a cohort of 200 French women, as far as I know, the papers that they've published. So it's yet to be validated in other populations.
Yeah, that surprised me, I have to say, because you know, for a study that was published last year, you know, albeit very exciting and promising, to get to the lab and for us to get announcements that actually you can use this test, I was amazed. So yes, you're absolutely right. I can't agree more that one has to be very careful before interpreting and using the test without it being reproduced and restudied in our population.
With bigger numbers, absolutely right. I just want to also point out that this group is also, they also have their own tests that are, and upon, well, from what I read in the news, I think they're going to be going live quite soon with their own tests that they've came up with.
Okay. Just to add that the problem is there are a lot of women desperately looking for answers for their pain, and if we have significant false positives, and I understand that they are claiming that the specificity is around 97-98%, which is phenomenal, but false positive in this group is going to be very difficult, because then you do a laparoscopy, you don't find a problem, and then, you know, everybody is in a bit of a pickle. Okay, we have one more paper before Andrew.
So the last paper that I will be talking about today is a paper on the systematic review looking at dietary interventions in the treatment of endometriosis. This was produced by a group from Switzerland and published in Reproductive Sciences just last year. So they included all original studies looking at dietary interventions on women with endometriosis. They looked at animals who were induced with endometriosis. So they managed to get 318 studies, and then finally rounded it down to 9 human studies and 11 animal studies. So for the animal studies, I'm just going to briefly talk about the findings. So they found that high-fat diet increased the number of endometriosis lesions. Omega-3 polyunsaturated fatty acids induced the regression of endometriosis, and calorie restriction led to the reduced endometriosis lesion weight. This next slide is on the 9 human studies which they found. So I'll just go through this really slowly with you guys. So the first 2 studies, the ones yellow in color, are RCTs. The ones 3 to 6 purple in color are prospective studies. 7 and 8 in blue is our retrospective studies, and number 9 is a qualitative studies. In the middle is the dietary interventions which the patients had, and the duration of intervention. 3M is 3 months, 6M is 6 months. And essentially, all of these studies over here did show a positive effect in the patient's pain symptoms with dietary intervention, apart from study 1, which was an RCT looking at giving vitamin D supplements to patient after a laparoscopy and still had persistent pain symptoms. Study number 3 as well, they did not look at the patient's pain symptoms, but they measured the blood oxidative stress markers, and they concluded that by giving antioxidants, their blood oxidative stress markers did go down. So 3 studies look at antioxidants. The type of antioxidants they looked at was things like vitamin A, B3, vitamin C, vitamin E, turmeric as well. And this is because endometriosis is associated with a chronic inflammatory response, and oxidative stress is a potential proposed factor that was contributing to this. Studies 6, 7, and 8, these 3 studies showed more than 70% showed an improvement of the symptoms with dietary intervention, and there was a statistically significant difference in this group. Study number 7 was quite interesting. They looked at women with IBS. 59 of them had endometriosis. 101 did not have endometriosis. And with the low FODMAP diet, the patients with endometriosis were 3 times more likely to respond compared to those without endometriosis. So the author did conclude that there was a lot of heterogeneity in these studies, but what can we do with all this information? So if a patient came to your clinic asking for a dietary intervention or some dietary advice, what they've advised is first, number 1, ascertain whether or not the patient has any GI symptoms such as abdominal pain, bloating, constipation. If the patient does have that, then offer them a gluten-free diet, a low FODMAP diet, or a low nickel diet. Whereas if the patient does not have any GI symptoms, then you can offer them a Mediterranean diet, because the Mediterranean diet also has a lot of antioxidant properties, anti-inflammatory properties, and also offer other health benefits as well. Granted, we know that these kind of diets can be expensive, can be time consuming to prepare, and may not be suitable for someone who has a very busy lifestyle. And what you can offer them is you can offer them an antioxidant diet for up to 6 months. So with supplements like vitamin B6, vitamin A, or vitamin E, and then see how they respond to it. So I found this paper really interesting, actually, because haven't really looked much into research with dietary interventions.
So we have another final poll that we're going to launch now. What that study tells me really, of course, you know, it's not a very high quality study, and although it does look at a couple of very small RCTs, but it just makes me curious that there might be something there. I've seen in my patients that dietary intervention can be helpful. So we always offer as part of the pathway, if you like. The ones with more gastrointestinal symptoms tend to do better with diet. But I think, I don't know what you guys have seen in your practice, but just the fact that the patient will take charge of some sort in their treatment is a positive. You know, whatever lifestyle change, if it's diet, if it's exercise, whether or not we have good evidence for it, but these are the things that actually will get the patient, will give them the feeling that they're in charge of their health, they're doing something. And in a lot of our patients, we've seen that it works, but it probably needs a lot more work. So yes, it's divided.
Very divided.
Room. So, but more yeses than nos. That's interesting. So it's interesting that a lot of people are using. Okay, now, finally, let me introduce Professor Andrew Horn, who, as I said at the beginning, is one of very few people, at least in the UK, who's currently doing very serious work in research. He also is an endometriosis surgeon and runs an endometriosis center in Edinburgh. He published with his colleagues a review in the journal Cell. And I really enjoyed reading it, and I thought it would be excellent if he can share some of the points of that review with us. Andrew, thank you for accepting our invitation.
Thanks.
Avril, you need to give host to.
Yeah. So thanks very much, Shaheen. I've really enjoyed the format of this evening. I think it's a really great idea. So as Shaheen said, we published this review back in May 2021. My co-author is a basic scientist, Professor Philippa Saunders, who's a professor of reproductive steroids in Edinburgh. And it's a fairly big review. In the review, we covered advances in our understanding of what causes endometriosis. We discussed current diagnostic and treatment strategies, and I'm afraid, Shaheen, I'm not going to talk about diagnosis in the interest of time. I've just focused on various aspects of the review. We highlighted current clinical trials which were active for new medical treatments, and then considered how results from preclinical studies offered new avenues, largely for non-hormonal treatments for endometriosis. I'm really going to focus on the latter two parts of the review, but just as a reminder, we put together this cartoon, which I think really just emphasizes how complicated a lesion is. If you look at all the different cell types that are thought to be involved, all the different processes. So you need immune cells recruited into the lesion. You need the fibrosis, you need hypoxia, you need processes such as angiogenesis and a newer term, neuroangiogenesis, formation of new nerves and as well as blood vessels. We know as well that changes in the microenvironment are important, including metabolic programming. So it's a really complex system that's going on there to lead to the formation of a lesion. But as I said, I just want to really spend the rest of the time looking to the future and looking to trials that are currently recruiting. And these tables are actually taken from the review, but I updated them this week just because, of course, things have changed since we wrote the review. So in terms of current phase 3 trials that are actively recruiting or where recruitment has been completed and analysis is ongoing, these are the 4 trials that I could identify. I thought it was interesting that Avril had shown a publication on Dynagest as another one, comparing Dynagest to an oral progestin that's currently recruiting at the moment. And then I think as a follow-up to the Spirit 1 and Spirit 2 trials, which looked at Relegulix, which is the GnRH antagonist with ADBAC-HRT, there are 2 other drug companies looking at Linzagalix, which is again in combination with ADBAC-HRT, and again looking at Elagolix, which is in combination with an oral contraceptive this time. And then there's this really interesting looking study which is looking at the extract from the fruit of a native Indonesian plant, and this plant's said to have antigenic, anti-inflammatory and anti-apoptotic effects. There are also a number of phase 1 and phase 2 trials which are currently ongoing, and I've listed these here. You can see that there are trials which really are targeting the inflammatory milieu. There are trials which are targeting angiogenesis. There are 2 studies looking at dopamine receptor agonists and their effect on endometriosis. And then there's an interesting one looking at green tea. And then finally, there's one which is targeting a receptor on primary afferent neurons, the purinergic P2X3 receptor. So this is really taking into account the fact that endometriosis is a pain condition. And then if you look forward, which is what we tried to do in the review, and categorize the different research areas which are active in the preclinical arena, if you like. There are studies looking at endometriosis as an inflammatory disorder, studies looking at it in its sort of context as a chronic pain condition, studies looking at treatments which target the peritoneal microenvironment and really target the fact that it's likely, particularly for pelvic endometriosis, that lesions form not just because of abnormal eutopic endometrium, but because of changes in the peritoneal mesothelial cells. And then we also looked at drug treatments which were essentially dietary supplements, and again it was interesting seeing Avril's review published there. So if we look at what's happening in the field whereby researchers are targeting endometriosis as inflammatory disorder, there are two cytokines, interleukin-1 and interleukin-33, which are promising new therapies. And this is supported by evidence largely from mouse models using monoclonal antibodies directed against these ligands. And you've got to remember, a lot of these models are only good at perhaps showing an impact upon volume of disease. There are very few models which also look at impact upon animal models that look that show impact upon pain symptoms. Prostaglandin signaling has also been investigated as a therapeutic target, and this really attention has been directed to testing inhibitors of the receptors that mediate the effects of prostaglandin E2, and this is because we know that PGE2 is expressed in lesions, and we know that it's a mediator of nociception in inflammatory conditions. And we ourselves in Edinburgh have carried out some studies, again using a mouse model, but a mouse model which allows us also to look at lesions as well as pain responses that have targeted PGE2. There are a number of different therapies that are targeting endometriosis, thinking of it as a pain disorder. I mentioned P2X3, which is a receptor expressed on primary afferent neurons, and this has gone into clinical trials largely because of work looking at rat models of endometriosis. There are a group of inhibitors called the CGRP receptor inhibitors, which are largely drugs which have been used in migraine. And again, these have shown promising results in a preclinical model of endometriosis, but have yet to be taken into clinical trials. But I suspect that will be something that will be happening within the next few years. And then, of course, there's this whole field of cannabinoid research, which I think we're going to see a lot of. Clearly, lots of patients use cannabinoids derivatives to manage their pain in endometriosis, and certain synthetic agonists have been started to be explored in preclinical models of endometriosis. And in Edinburgh, we've just received funding in the last few weeks to carry out a randomized controlled trial comparing a cannabinoid tincture versus a placebo to see what impact it has on endometriosis associated pain. There are a number of inhibitors of, again, a receptor expressed on pain afferent neurons, TRPV1, that have been used in other pain conditions, but it's interestingly, these don't seem to have shown any effect in endometriosis models. So again, this has been a bit of a disappointing avenue in terms of preclinical work. And then there's been work which has targeted metabolic endpoints, and this is some work that we've led in Edinburgh. So we've shown using samples from patients and using preclinical non-animal models that it appears that the microenvironment that's important for an endometriosis lesion to develop relies on an increase in glycolysis and an increase in the production of lactate. And lactate's interesting because it's important in tumorigenesis for the steps that are important for the formation of a lesion. So steps like adhesion, invasion, and angiogenesis. So we have been doing some work targeting the production of lactate in the pelvis of patients with endometriosis. And you can see here from this animal model of endometriosis, by giving lactate, we've been able to reduce the volume of disease within the pelvis of these mice. And we've just taken this into an early phase exploratory clinical trial and about to start a randomized clinical trial comparing DCA to placebo. And then there have been strategies looking at symptom management based on dietary supplements and natural products. And this has largely been because, as we've just heard, that food with a high content of omega-3 purified fatty acids have been shown to have an anti-inflammatory effect. And then if you look at some of the animal work that's been carried out, omega-3 purified fatty acids or polyunsaturated fatty acids reduce lesion size and also local prostaglandin production in these rat models of endometriosis. We carried out a pilot study comparing omega-3 purified fatty acids with olive oil capsules. It's very difficult to get a placebo because you can actually aware of the taste and the smell of the capsules. So that was the closest thing that we could use. And this was really a pilot study, more to inform a larger trial, but we couldn't find any efficacy of this treatment. And there was a similar study performed at the same time, which compared omega-3 purified fatty acids to vitamin D to placebo. And again, the change in pain scores was not significant, but again, this was an underpowered study. So I think there's definitely, as we've just heard, a lot more work to be done in this field. And then, of course, there are interesting other studies looking at other derivatives, such as turmeric, resveratrol from grapes and berries. So that's why drinking red wine is meant to be good for you, but these sorts of things are also being investigated. So we concluded our trial by summarising that there are lots of exciting new avenues and therapies on the horizon, and that they can be broadly characterised into therapies that target endometriosis as an inflammatory, chronic pain or metabolic disorder, as well as those that capitalise on the link between diet and pain. But I think our main conclusion was that to move the field forward, certainly as researchers, we all need to work and widen our field and work in an interdisciplinary manner with biologists from other fields, experts on the metabolome, the microbiome, diet and data science. I think also there's a huge opportunity to repurpose existing drugs. I mentioned some of the anti-migraine drugs we could look at. There's drug companies now publish drugs that have sort of failed at the last hurdle now, and there are lots more opportunities to test these drugs out in other conditions. So again, repurposing I think is something we'll see more of. And then of course we do have a wide range of existing treatments, both surgical and medical treatments. So I think the field would really benefit from markers that can predict response to treatment. It would be lovely if you could see a patient in a clinic and do a blood test and tell them which of the treatments that you have in front of you, whether that be surgery or medical management, is the most effective thing for them. And then lastly, I hope you don't mind, Shaheen, I just popped an advert in for the World Congress on Endometriosis, which we're hosting in Edinburgh in May, and everybody's very welcome to attend.
Yeah, that's lovely, and thank you very much for the wonderful presentation, Andrew. It's just amazing to see how much work you're doing up there in Edinburgh, and how much we're going to see the result of these. It will take time, I'm sure, but and a philosophical question for me always is, you know, in one extreme we have people who say, you know, endometriosis should be treated like cancer and you have to do surgery when you see endometriosis wherever it is, even if it's a asymptomatic patient. On the other extreme, I think we'll have people who say surgeons are all horrible people and you should never touch a patient. And I guess the truth lies somewhere in between. You know, it's more and more we understand about endometriosis, and I guess we'll get closer to where we need to be. But I want to ask you a question, Andrew. Do you think part of the reason we are not able to get proper answers to many of these questions is the nature of the outcome measure, which is usually pain, and the measurement of that pain and the placebo effect? Do you think that's part of the problem?
Yeah, I think that's a really good point. It's interesting if you speak to, so often we get approached by industry, and you know, if they're wanting to run a trial of a new product, they get quite frustrated because to them a questionnaire, a pain questionnaire, isn't a great outcome measure, and they would, you know, they want to see an impact upon, you know, disease volume. And obviously, you know, it's easy to study an endometrioma and decide whether or not you can reduce the volume of that, but much more difficult for, superficial peritoneal disease. I mean, I suppose as imaging gets better, we might be able to study that side of things in clinical trials. But I suppose the big thing would be if we had a nice biomarker and we could show that that fell off, like HCG does for when you're treating an ectopic pregnancy, that sort of thing. So.
Yeah, which reminds me, I don't know if any of the biomarkers that have been tried are claiming to go down once the disease is treated. I don't know. I haven't read it anywhere. It would be interesting.
Yeah, I think there've been some work, hasn't there, on CA125, which obviously isn't a good biomarker, but I think there's been some work looking at whether it falls with treatment. It's often incorporated into some of these industry studies, but not hugely helpful.
Yeah, so I reviewed a paper. Maybe I can't say that because it's not published. But yes, they looked at hundreds of markers, and CA125 was. Okay, let's see if there is any questions. We've been really lucky with our speakers today, and there are two announcements to make. We've run 25 minutes late. We are aiming to finish these within 1 hour, but maybe we should advertise them as an hour and a half and make sure that we have a little bit more time. Two things I want to announce. One is that from next month, we are going to add another feature to these meetings, and that is our team is going to go out and find the answer to one relevant clinical question. For example, next month, our question is going to be, what's the value of CRP in post-operative care for patients after surgery for endometriosis? And there are actually some very interesting papers on that, and I learned a lot reading them. So we will bring that the answer to you, but please email Ben. Ben is going to put his email address in the Q&A. If you have any questions that you want us to find the answer to, or even better, if you want to volunteer to present the answer to that question in a 5-minute presentation, just one question, and then the difference to the 6 papers that we're presenting is those are just presenting those papers, but that answer to question would require critically appraising the papers that you read, so that people can actually rely on your answers. And the second announcement is next month. Ben, you may want to say what we've got next month for our LEJEndo. We have some very interesting papers coming up.
So yeah, we have 2 really nice, interesting papers. The first one is going to be presented by Harald Krantel, and is going to look into the time that is required for morcellation forced through precervical hysterectomy, and he's going to compare when this is done in bag and when it's uncontained, which is really, really interesting. I was really surprised of the results. And the second paper that you already mentioned is by Professor Carmona, and is going to look at the impact of surgery for deep endometriosis when it's done before in vitro fertilization. So that is a systematic review and meta-analysis, which is really, really interesting as well.
Okay, on that note, I want to thank our featured presenters one more time, Gabby and Andrew, excellent presentations, and thank you for taking the time, giving up your evening to do this. And I say goodbye to everyone.
Thank you.
Thank you, everyone. Good night.
Bye, everyone.
Bye-bye.